Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
For decades, MASH has lived in the shadows, underdiagnosed, undertreated, and carrying a far greater burden than most of us ever imagined. But today, the future for people living with liver disease has never been brighter. We have better diagnostics, more treatment options, stronger evidence, and a clearer path to preventing and reversing fibrosis. Welcome to the final episode of our Medscape series, Breaking the Silence, tackling liver fibrosis in metabolic-associated steatohepatitis, or MASH for short. I'm Sharon Thomas. In this three-part docu-series, we've travelled across Europe, speaking with some of the most brilliant minds in fibrotic liver disease, the guideline authors, patient advocates, and world-class researchers driving remarkable advances in MASH management. Their insight has been extraordinary, and as we move into our final episode, let's remember this key point from those discussions. It's fibrosis that decides the patient's future, not fat and not inflammation. Fibrosis stage is the strongest predictor of liver-related events and mortality, and we can now assess it non-invasively with enough accuracy to guide everyday clinical decisions. Which brings us to Antwerp, Belgium, and the clinic of Professor Sven Franke, renowned expert on non-invasive testing and its application in risk stratification and tailored treatment. Today we'll follow a hypothetical patient who has obesity and type 2 diabetes, from risk evaluation to stratification to treatment and follow-up. Let's get started. Professor Franke, thank you so much for the warm welcome.
It's my pleasure.
So I understand you see quite a few patients with MASH in your outpatient clinic.
Yes, it's a busy teaching hospital and we run a multidisciplinary hepatology clinic, managing the full spectrum of liver diseases. I don't know the exact numbers, but I'd say we're around 6,000 patients with liver disease a year, many of who have MASLD or MASH.
It's remarkable, and with that in mind, let's imagine a man in his early 50s who has obesity and long-standing type 2 diabetes. He's already on a GLP-1 receptor agonist and has achieved some weight loss, but his liver enzymes remain modestly abnormal and an ultrasound has shown steatosis. Is this a patient you would typically see?
Yes, that profile is very common in our practice.
What makes this patient particularly vulnerable to MASH and liver fibrosis?
Well, you've mentioned the powerful combination of risk factors: clinical obesity, type 2 diabetes, and him being in his 50s. Clinical obesity is not just based on body weight. It reflects how adipose tissue is distributed and how well that tissue can cope with caloric overload. What really matters for MASH is adipose tissue dysfunction, especially in visceral adipose tissue, where chronic hypoxia and low-grade inflammation drive insulin resistance, lipolysis, and the release of free fatty acids and inflammatory mediators. Those mediators will then affect multiple organs, including the liver, where they can drive steatosis, hepatocyte injury, and activation of fibrogenic pathways.
Oh, so not all obesity carries the same hepatic risk?
No, those with dysfunctional, inflamed adipose tissue, often with central obesity and long-standing diabetes, are the ones at particular risk for steatohepatitis and fibrosis.
And how does having type 2 diabetes add to this patient's risk?
People living with diabetes, they tend to progress more rapidly to advanced fibrosis and cirrhosis than those without diabetes, even at comparable levels of steatosis. There's a multi-directional relationship happening here. Chronic inflammation and steatohepatitis worsen glycemic control and lipid metabolism, while poorly controlled diabetes in turn exacerbates liver injury and fibrosis progression. Over time, the duration of obesity and diabetes matters. A man in his mid-50s is not old, but years of metabolic stress give ample opportunity for cumulative damage and advancing fibrosis.
Risk factors tell us who might be at risk, but they don't reliably tell us who will progress or who already has significant fibrosis. Every undetected case of moderate F2 fibrosis is a missed opportunity to prevent cirrhosis, liver cancer, and even death. That's why guidelines now emphasize active case finding. Clinicians are advised to look specifically for fibrosis using non-invasive tests in people with type 2 diabetes, abdominal obesity, plus additional metabolic risk factors, or with abnormal liver tests or imaging showing steatosis. Our patient is exactly who the guidelines are telling us not to ignore. He has type 2 diabetes, obesity, abnormal liver enzymes, and imaging evidence of steatosis, each of them a clear trigger for case finding. As a member of the EASL and EASD guideline panel on MASLD and MASH, Dr. Franke helped shape the current recommendations on stepwise, non-invasive fibrosis assessment. Let's find out how he would evaluate this patient. Professor Franke, how would you assess risk in this patient with long-standing type 2 diabetes and obesity?
In a patient like this, my first step is to review the liver biochemistry and calculate a simple fibrosis score, most commonly FIB4 because it's inexpensive, accessible, and has a high negative predictive value for advanced fibrosis at low cutoffs. This is also what the guidelines recommend as an initial screen. If FIB4 is low, less than 1.3, the likelihood of advanced fibrosis is small, although we will reassess every 1 to 3 years because risk can change over time. If FIB4 is high, more than 2.67, we consider the patient at high risk and arrange further workup in hepatology. For those in the intermediate gray zone, roughly between 1.3 and 2.67, there are two options. Either optimize metabolic control and weight management, and then re-evaluate after 6 to 12 months. Or move directly to a second-line test such as liver stiffness measurement or a serum fibrosis biomarker. These are used to identify F2 or F3 stage disease. The decision is often made based on imaging availability and whether there's still room to improve glycemic control and weight with higher GLP-1 receptor agonist dose, lifestyle support, or other cardiometabolic drugs.
How does this guidance translate into your own clinical practice?
We follow the same general framework that's described in the guidelines, but we go slightly beyond the screening guidance. In our patients who have diabetes and obesity, we use ultrasound with liver stiffness measurement as a baseline screening tool, in addition to calculating FIB4, of course. That gives us both structural and stiffness information at least once. And then we tailor follow-up based on those results, but that approach, as said, is specific to our setting.
And once you have that liver stiffness value, how do you use it to guide your next steps?
We interpret liver stiffness using a threshold of about 8 kilopascals in MASLD. Below that, in the context of reassuring lab results, the risk of advanced disease is low. If it's above that, we'll repeat the measurement to confirm, because it can vary. Increased subcutaneous fat and hepatic steatosis, they may slightly overestimate stiffness, particularly in early fibrosis. And factors like propositioning, transient inflammation, or congestion can also inflate measurement. If a liver stiffness value above 8 kilopascals is confirmed, we consider significant fibrosis more likely and will proceed with more intensive evaluation and management. But it's important to note that if liver enzymes are persistently elevated, we must also exclude other chronic liver diseases, such as viral hepatitis and autoimmune liver disease, regardless of FIB4 or liver stiffness results.
How often do you still see scenarios where you would do a biopsy at this stage?
Biopsy may be useful when non-invasive tests are discordant, when we suspect overlapping liver diseases, or when inclusion in a clinical trial would require histology. But for many patients, non-invasive tools now give us enough confidence to initiate treatment and to monitor progression.
Non-invasive tests like FIB4 and liver stiffness help us separate those at low risk from those with clinically significant fibrosis. They also help us to identify patients with MASH in stages F2 or F3 when they're most likely to benefit from treatment. Professor Franco refers to this time as the actionable danger zone. Let's find out why. What makes the window between F2 and F3 so critical?
In F2, we still have a window where regression is realistic if we remove the metabolic and inflammatory drivers and use effective therapies. Whereas in F3, the transition to cirrhosis can occur over only a few years in high-risk patients, like ours. So, the risk of evolving to true liver-related events is substantially higher in F3, and the closer the patient gets to cirrhosis, the less likely their chances for reversal.
I see. So let's say we've confirmed our patient has MASH with early F3 fibrosis. As before, he has obesity and long-standing type 2 diabetes. He's already on a GLP-1 receptor agonist and has had some weight loss, yet he clearly remains at risk. How do you approach treating liver fibrosis in this setting?
I think it's important to clarify what we mean by treating fibrosis. Fibrosis does not develop in isolation. It's a downstream consequence of steatohepatitis, meaning repeated injury and inflammation in a liver that is overloaded with lipids. That in turn is driven largely by dysfunctional adipose tissue, insulin resistance, and related metabolic stressors. So, for our patient, the first step remains a comprehensive conversation about the nature of his liver disease, explaining that his liver is inflamed and fibrosing from the same metabolic factors driving his diabetes can motivate him to pursue lifestyle changes and structured support for weight loss, physical activity, and nutrition. We then optimize what he is already receiving, maximize the GLP-1 receptor agonist dose as tolerated, bearing in mind that doses for weight management may be higher than those used purely for glycemic control. Then we ensure he is on appropriate background therapy, statins, and in some cases aspirin, because although their direct hepatic effect is modest, over the long term, they may slow disease progression via vascular and anti-inflammatory mechanisms and clearly improve cardiovascular outcomes. In some countries, pioglitazone is also an option in patients with diabetes and MASH, given its benefits on steatohepatitis and fibrosis, although due to concerns about fluid retention and heart failure, it must be used selectively.
And where do liver-directed therapies such as resmetirom fit into this picture, especially if the patient is already on a GLP-1 RA?
So, in 2025, resmetirom received approval in Europe for patients with non-cirrhotic MASH and moderate to advanced F2-F3 fibrosis. Resmetirom works in a fundamentally different way than upstream cardiometabolic drugs such as GLP-1 receptor agonist. It's a selective thyroid hormone receptor beta agonist targeted to the liver, designed to improve hepatic lipid handling, reduce hepatic fat, and modulate inflammatory and fibrogenic pathways. Phase 3 data from the Maestro-NASH trial show that in patients with active MASH and F2-F3 fibrosis, resmetirom significantly increases the likelihood of both MASH resolution and fibrosis improvement by at least one stage, with no worsening of disease activity compared to placebo. GLP-1 receptor agonists like semaglutide act upstream on body weight, insulin resistance, and cardiometabolic risk. Accumulating evidence from phase 2 and 3 trials are showing that semaglutide can also improve fibrosis histology over time through both weight-dependent and weight-independent mechanisms, typically with prolonged treatment. Resmetirom directly targets intrahepatic mechanisms, which is particularly relevant in patients who already receive intensive metabolic therapy but still have significant fibrosis. For a patient like ours, whose GLP-1 receptor agonist dose has been optimized and who still has F2-F3 disease, we would add resmetirom, assuming he meets the indication of active steatohepatitis with fibrosis.
So you're comfortable with combining it GLP-1 RA with resmetirom?
Yes, provided we respect the usual precautions. There's no mechanistic reason to expect problematic interactions. The GLP-1 receptor agonist addresses extrahepatic metabolic drivers, whereas resmetirom is liver-targeted. And subgroup analyses of patients on background GLP-1 receptor agonist therapy in the resmetirom trial did not indicate any major safety or efficacy concern with the combination. We would monitor thyroid function and other routine safety parameters as recommended, but I'm otherwise quite comfortable with this combination in appropriate patients.
You also mentioned that access and indications can really vary across Europe. Tell us a bit more about that.
That's right. Resmetirom was the first drug approved for MASH. Its formal indication is active steatohepatitis and F2F3 fibrosis, but implementation will depend on national guidance and reimbursement criteria, which are not uniform across countries. At present, some centers have experience mainly through clinical trials, but the landscape is evolving rapidly.
We've covered a lot of ground, from active case finding to how to stage disease to management. Now that we've explored where liver-directed therapies like resmetirom fit alongside optimized GLP-1 receptor agonist-based care, the next question is, how do we know whether all of this is truly changing the course of fibrosis for our patient? In this final section, we'll shift our focus from what to prescribe to how to follow and look at the practical ways you can use non-invasive tests over time to judge treatment response. Once you have a patient on a GLP-1 RA with added resmetirom or other agents, how do you monitor treatment response in terms of fibrosis risk?
We should distinguish between regulatory endpoints and clinical practice. For drug approval, we rely on histologic endpoints, such as MASH resolution without worsening of fibrosis, or at least one-stage fibrosis improvement without worsening of MASH. In everyday practice, I'm already satisfied if I can halt disease progression. Preventing a patient with F2 from moving to F3 or F4 is clinically meaningful, even if we don't see clear regression.
Which tests and what sort of timeframes really convince you that you're moving in the right direction?
In terms of monitoring, we look at several parameters together rather than a single test. Transaminases and routine liver tests can typically be checked every 6 months. We want to avoid persistent deterioration and ideally see normalization or at least sustained improvement. Liver stiffness is typically reassessed once a year, given costs and variability, and we pay attention to the trends rather than small isolated changes. Different studies have proposed specific thresholds for the magnitude of change, but in practice, the key is consistency across more than one parameter. If both liver stiffness and enzymes are stable or improving over serial measurements, we can be reasonably confident that the liver condition is at least not worsening and perhaps improving. If both worsen despite intervention, that signals that we need to reconsider our strategy.
So you avoid relying on a single test at a single point in time?
Yes, combining non-invasive tests and looking at trajectories over time gives a much more reliable picture of the true liver status than any one measurement in isolation.
And finally, what are the 1 or 2 key messages you most want our audience to remember?
Well, let's see. First, the relationship between liver disease, adipose tissue dysfunction, and diabetes is complex and multidirectional. It's not a simple process of cause and effect. Treating obesity through lifestyle and pharmacotherapy already has a profound impact on the liver and may spare many patients from needing additional therapies. And second, accurate assessment and follow-up depend on using combinations of non-invasive tests and assessing trends over time, rather than relying on a single tool or a single time point. This approach helps us identify which patients with F2-F3 fibrosis truly require escalation to therapies that specifically target MASH and fibrosis, and to judge whether those therapies are delivering meaningful benefit.
Professor Franke, thank you so much for those really practical and thought-provoking insights. Thank you.
My pleasure, I've enjoyed it.
As we close this series, let's revisit the patient we met in Antwerp, a man in his 50s with obesity, long-standing type 2 diabetes, and MASH with early F3 fibrosis. This is the face of a MASLD epidemic, not a rare disease, but a common high-risk phenotype encountered in clinics every day. F2 and F3 are the actionable danger zone, the point at which fibrosis becomes the strongest predictor of liver-related events and mortality, yet still offers a window where timely intervention can change the outcome. Non-invasive tests now allow us to find these patients earlier, follow them safely over time, and decide who truly needs escalation to liver-directed therapy without needing to do a biopsy in everyone. Agents like resmetirom add a new layer of possibility by targeting intrahepatic drivers of MASH and fibrosis directly in those with F2, F3 disease. Our challenge going forward is simple to state but demanding to deliver. Do not overlook the at-risk patient. Use non-invasive tools thoughtfully and treat liver fibrosis as an integral part of cardiometabolic care. On behalf of Medscape and with sincere thanks to Professor Franke and all of our experts, I'm Sharon Thomas. Thank you for joining us on Breaking the Silence, and thank you for everything you do to change the trajectory of MASH for your patients. For this episode, do remember to complete the post-activity quiz and evaluation to receive credit. Until the next time, goodbye.